Hi and welcome everyone to the NEET PG 2023 recall OBS GYN. I hope all of you did fantastic in this examination. This is your OBS GYN faculty for GAME, Dr. Sunabha. I did my MS from ZIPMER, subsequently DNB. So let us start with the question. And this year there was a lot of questions on sexually transmitted infections and management. So let us do that segment first. So there was this question. It was an image-based question. I didn't find the exact image, but what I heard, the image was pretty elaborate. Lady with multiple partners comes with painful swelling in the vagina with difficulty in swelling, and the diagnosis was clear. The image that was a clear giveaway that that it was a Bartholin cyst. So next question was female with multiple sexual partner with lower abdominal pain, greenish discharge, and PV. So there was a question about weight smear finding, if I am not wrong. So the exact motility and the characters of that organism will be discussed by our microbiology team. But there was this question. They talk about greenish discharge, and they talk about an STI, and I think. And in that case, if the diagnosis is likely to be trichomonas, which is supposed to give rise to this kind of an organism, which is the trophozoite form of it, and showing twitching type of motility. So let us just recollect this. We did that if there is a greenish frothy discharge and there will be trophozoites. So we discussed this repeatedly. So we have discussed this previously multiple times. So next question, wife of a long distance truck driver with vaginal discharge and verrucous lesion on vulva. So which color kit to be given? So this syndromic management and NSEO kits has been multiple times discussed as must know topics. And if you can see this list, there is no specific kit for verruca separately. So there is no kit for verruca. We have to treat only for the vaginitis, which is the green kit, right? So this question has been discussed before. What does the green kit contain? And see, I told you previously also, if you have to remember three, then you have to remember gray kit, green kit, and the red kit, right? So let us see the next question. Cervical cancer has spread to the parametrium. Spread to the parametrium means at least it is stage 2, and beyond stage 1B, everything is chemo radiation. So this has been discussed before. See, if it has gone to parametrium, then it is stage 2B at least, and all of this goes for chemo radiation. Only chemo is for stages which are very high, like stage 4 and 4B. So female phenotype with bilateral inguinal masses with no secondary sex character, absent uterus and tubes on imaging. So bilateral inguinal masses means they have totally given away the diagnosis that this is the testis which is undescended, and the diagnosis is complete androgen insensitivity syndrome. But let's just see how to approach this kind of question. See, this is a question where there is no doubt about it is an absolutely, there is no adrenarche in primary amenorrhea. If there is no adrenarche, there is no pubic hair, it is AIS, right? That's what we have discussed repeatedly. This chart from Spirov we have done. Like if she is asymptomatic, like normal female phenotype, no problems otherwise. So if there is normal pubic hair, it is MRKH. If there is scanty or absent pubic hair, it is AIS, androgen insensitivity syndrome. Right. Next one was another IBQ on partograms, which the question I could not recollect properly. It read, it was showing second stage of labor with full dilatation of cervix for at least 1 hour, rupture of membrane for 2 hours. There is MSL, grade 2 molding. I don't know how long she was on oxytocin, and what was the exact vertex station. So this information is particularly pivotal, and if the vertex was low, like somewhere around +2, +3, so the head has descended significantly, then the answer would be forceps delivery. And if there is vertex region is high up, like not amenable to low forceps, then the answer would be immediate cesarean. There was mention of fetal heart rate, but I'm not exactly getting what it was. It was, someone says it is less than 100 and someone was saying it's more than 120. So if it is more than 120, that is reassuring fetal status, and we can still go for low forceps delivery in a favorable station. On the other hand, if the vertex was um, vertex was high and the fetal status was not reassuring, emergency cesarean would be the answer. So based on the exact options, the answer would depend. But I don't think you would have problem, because we have done this partograph type of question and details of partograph again and again in our sessions. So the next question was female on HMG injection, which is basically a form of ovulation induction, Human menopausal gonadotropin. Menopausal gonadotropin contains nothing but FSH. It is like when the woman is menopausal, then the ovaries are not functional, so there is a very high bombardment from the pituitary gland and FSH will be very, very high. So that FSH only will reflect in the urine of that postmenopausal woman. So human menopausal gonadotropin is basically another name for FSH, and it is often used for ovulation induction. So someone on ovulation induction complains of pain, abdomen, nausea, vomiting, and this imaging was shown. This has been discussed previously also, that this image can be either a multiple septate complex ovarian cyst or a picture of OHSS, and you have to look for the history, and here the history is abdominal pain and there is history of ovulation induction, so this one becomes OHSS. Next question was, a currently pregnant lady delivered healthy twin few years back. What is her GPLS score? So she is pregnant now and she delivered one baby previously, so it is twice she became pregnant. That pregnancy definitely crossed viability. So one, there was twins, so 2, but P doesn't increase, only L increases, and there is no talk about abortion. So it answer becomes G2P1 L2A0. You must have made this answer correct, because despite being such a simple topic, I have discussed this question twice in our revision sessions, TND sessions, so that you do not miss a seater question, because once you miss a seater question, your chances become very lean in cracking the exam. So this was another question from Anemia Mukt Bharat guidelines. 7 weeks period of gestation comes to antenatal clinic with hemoglobin 9 gram per deciliter, which is basically a moderate anemia. So when to start iron therapy? She is 7 weeks. So iron therapy is to be started at 13 weeks as per Anemia Mukt Bharat guideline. So 12 to 14 weeks becomes the correct answer. See, this is the Anemia Mukt guideline, and what week, what hemoglobin, what to do, that beautiful flow chart that has been given, and this is discussed. I hope you have made the answer correct. Uterine height more than period of gestation. Uterus is tense but not tender. So on palpation, fetal movements are normal, but difficult to palpate individual parts. Right? So what is the diagnosis? So let us rule out one by one options. If it was APH or abruptio placentae, then uterus would be tender. So here it is non-tender. APH ruled out, and there is also no history of bleeding PV as well. So if there was maternal and fetal ascites, so if mother's abdomen had also fluids, then it would be extremely difficult for us to palpate the uterine height specifically. So that is also ruled out, because we can palpate the uterine height. And I think they have they have measured the symphysiofundal height as well as 40 centimeter or something, if that's what I collected. So if it is a macrosomia baby, it would not become difficult to palpate the individual parts if you can feel the fetal movements. But if there is polyhydramnios, then the mother can feel the fetal movements, but we cannot feel the specific terms, because there is more fluid in the uterus. Uterus will be enlarged and tense. But will not be non-tender. will be non-tender. So answer becomes polyhydramnios. So simple question. Primi gravida delivered full-term male baby by vaginal route in known case of bronchial asthma developed PPH with uterine atony. So which drug is contraindicated? Of course, in bronchial asthma, if there is a history of bronchial asthma, carboprost is contraindicated. And this thing we have discussed when we discussed the general discussion on uterotonics. And again, when we discuss questions like this, see one line we have highlighted, right? That PGF2 alpha adverse drug effect is bronchospasm, contraindicated in bronchial asthma. So this should not be a problem. Also, again, we have discussed one more question specifically on carboprost, highlighting that asthma is a contraindication. So next question, multigravida 36 weeks 6 days, so almost term with transverse lie, hemodynamically stable. So they have given intentionally this statement hemodynamically stable so that you don't jump up and don't do elective cesarean or IPV like emergency procedure. So that doubt, the two correct options are conservative versus ECV. Now it cannot be conservative because usually all that spontaneous turning and version happens till term. So this is already term. So our option would be external cephalic version. So we will assess our pelvis and plan for external cephalic version. So that is the answer. There was another question, primary amenorrhea with cyclical pain abdomen with suprapubic mass felt on PR anterior to the vagina till the lower end of vagina. So they have said till the lower end of vagina, and there was no mention of the hymen. So if it is till the lower end of vagina, the obstruction is at the lower end of the vagina, then it is most likely to be a hymenal obstruction or imperforate hymen. Imperforate hymen. On the other hand, if it was at the 2/3 1/3 junction, if it was mentioned at the 2/3 1/3 junction, or if they mention that there is no specific bulging membrane, they have mentioned about hymen, the question would have been easier. So if they had mentioned something about 2/3 1/3, then the answer would have been transverse vaginal septum. But this question not very clear, but the correct answer seems to be imperforate hymen, and this is the most common thing. So this thing we have discussed once before. Like if you have a doubt between imperforate hymen and transverse vaginal septum, it's not very clearly given that this is the diagnosis, then better to go with imperforate hymen if the condition is more common, because common things are commonly correct. Mother-in-law brings a 23-year-old daughter. So the key thing was 23-year-old, and everybody was like, the recalls I got, everybody was so obsessed about the mother-in-law, daughter-in-law thing. But the point was she is 23-year-old. So she was brought about at 6 months for infertility, and at 6 months we do not do any investigation. To define as infertility, we need 1 year of unlimited, unprotected coitus. So we should reassure and ask them to follow up after 6 months if they fail to conceive. We can also start folic acid preconceptional at this point because they are trying to pregnancy. What we can do is we can explain the most fertile period of the cycle, but that's all intervention we can do at this point. If she was not 23 and if she was around 35, then we would have started our workup at 6 months. So then the correct answer would be husband semen analysis and primary infertility workups like thyroid profile and basic ultrasound. This is a classic triad, PDA with sensorineural hair loss, sensorineural hearing loss with cataract, and they asked about which congenital infection. So we had done this question. The triad we discussed is PDA, cataracts and microcephaly. This also causes sensorineural hearing loss, but this PDA and cataract are so significant of rubella, congenital rubella syndrome. PDA and cataract is not seen in any others. Like chorioretinitis, SNHL, microcephaly, mental retardation, this will be common between all the congenital infections, but PDA and cataracts is something that you don't get to see everywhere. Mostly eyes you will see chorioretinitis, but not cataracts. Cataract is a typical of rubella. There was another question on congenital infection. The key word that much I could got is periventricular calcification. So remember, periventricular calcification is a characteristic of cytomegalovirus infection in the mother. And remember things like CMV, C stands for choreo, and this C is like ear, so it is deafness, sensory neural hearing loss. And then M stands for microcephaly and mental retardation, whereas V is for periventricular calcification, which is different from toxoplasma, which causes brain parenchymal ring enhancing type of calcification. Also, this is a very famous mnemonic that has been very popular. Now, I made this with made yellow highlights on the face with red dots to remind you that it also causes hyperbilirubinemia and pitacy. Was another very straightforward, simple question, basic conceptual question. Pregnant lady lie on supine, feels dizzy and relieved on sitting. So, what is the reason? It is postural hypotension. It is postural hypotension in the pregnant women because of IVC getting compressed, and the drainage from lower limb is the venous return from the lower limb is obliterated, and there is a relative hypovolemia. There is a relative hypovolemia because IVC is compressed by the full gravid uterus when she lies on the supine position, and that is why the position that is advised to ladies is lateral position, specifically left lateral position. So this is one important question that is there in every alternate year question. So ectopic pregnancy, when to do medical management, versus surgical management. So there are certain criteria to be fulfilled for medical management. One is the mother has to be stable, mother has to be hemodynamically stable. So our patient, she is hemodynamically stable. If there is no cardiac activity, the results are better. It is not like it's absolutely contraindicated to give methotrexate. If HCG is less than 2500, the results are better. Now this is different for different societies. Like Royal Society says it is 4,000, whereas British Society, the American Society might say it is 5,000. This is what I am saying. 2,500 is from Fertility Society of America. So everybody has their own guidelines, but if HCG is low, the success rate is high, and the sac diameter should be less than 4, or some society says 5, but here it is 3 millimeters, so way less. So overall, this lady qualifies for medical management. In medical management, there is no there is no conservative treatment for ectopic. Oral methotrexate, there is no such regime. Single injection methotrexate, 2-dose methotrexate, and multiple dose methotrexate, all three regimes are there, but multiple dose methotrexate is usually not preferred. I would not say this is a wrong answer, but this is a regime that is usually not preferred. So this is the regime: 1-dose regime and 3-dose regime, 2-dose regime. These are the two which are most commonly used, and hence single injection methotrexate will be the best answer for this. Methotrexate is given at 1 mg per kg single dose, and beta HCG is measured on day 4 and day 7 to appreciate if there is any fall. And alternatively, it can be given at 50 mg per meter square of body surface area, and beta HCG monitoring same day 4 and day 7. So next one question, I don't think any of you has made any mistake. Hysteroscopic management is possible for, yes, Asherman hysteroscopic management is possible. I have demonstrated pictures of it, I have demonstrated the instruments, and I have demonstrated specifically how the scissors goes and how the view is. So obviously you should know that hysteroscopic management is possible for Asherman. Now cervical polyp is just at the lip of the cervix, it is not within the uterus, and hysteroscopy is to see deep inside the cavity. So cervical polyp is not required, hysteroscopy is not required. And also, if there is a cervical polyp sitting, you cannot negotiate the scope. Of course, you have to take the polyp out and then only we can negotiate the scope, right? So subserosal myoma, no. If it is a submucosal myoma, If it is a submucosal myoma which is inside the cavity, then hysteroscopic resection, transcervical resection of myoma is possible, that we have discussed. But if it is somewhere around here or here on the outer surface of the uterus, then it is not amenable by hysteroscopy. And tubal ligation, of course, is not possible. Female permanent sterilization, assure, it was the technique that was hysteroscopic method of permanent female sterilization, but even assure is no longer available. So that leaves us with the answer, correct answer, Asherman syndrome. So here is a slide where we have discussed Asherman syndrome and how does the adhesions look like, and how does the hysteroscopic scissors goes and cuts it into pieces and relieves the adhesion, right? So last question, disadvantage of laparoscopic hysterectomy over TAH. So basically laparoscopic TAH is superior in terms of pain profile, in terms of recovery profile, in terms of surgical outcome, and in terms of like its quick recovery and less less blood loss and less post-operative pain. But if there is a electrocautery burn, since the visual fields and there are all electrosurgical instruments working inside, and we don't know which one is touching exactly within, because not all instruments are on our eye field. So sometimes injury to the burn injury to the particularly devascularization or ischemic injuries, devascularization or coagulation of part of vascular supply to the ureter or some part of bladder may be missed, and which will be a delayed manifestation. So that is the only advantage of TAH over TLH, that everything is under vision, everything can be seen, and it's easy to miss if there is a cautery going inside the field and inadvertently burning something, because we can get the smell, we can get the look, and everything is right in front of our eyes. So that's it, guys. I hope all of you have done really great in this exam, because the questions from option gynae was very basic, very conceptual, and most importantly, most of it was from the T&D sessions we already had. So rest well, let us wait for the results, and I hope we need not to meet for similar sessions again. All the best, good luck, bye bye.